Hi everyone, this is Madison Hammett with Illinois ACEs Response Collaborative. Thanks so much for joining us. We're going to give folks a couple more seconds to log on, so we'll give us just a minute or so, we'll get started. Okay, thanks so much, everybody. Thank you so much again for joining us for Clinician Burnout or Wellness. We are so excited to feature this webinar. It's the first in our series about burnout, and we're going to go ahead and get started. So, there we go. Thanks so much. And like I said, this is the first in an upcoming series, or current series now that we are featuring all about burnout. So today we are going to be hearing from Lara Altman and Audrey Stillerman with Clinician Burnout or Wellness. And then in March, we are excited to feature Linda Grab and Elaine Miller-Corres, who will be talking about the community resilience model and its applications in nursing and other settings. So not just for nurses, we hope all of you will join us on that day to prevent burnout. And then in April, we'll be welcoming Addie Stuart, who is a yoga therapist, and she's going to be discussing integrating yoga as trauma-informed wellness practices for practitioners and staff. And we have several folks who are joining us for the first time, so welcome. And just a little bit about who we are. The Illinois ACEs Response Collaborative is housed at Health and Medicine here in Chicago, and we work to promote social justice and challenge inequities in health and healthcare. And we're an independent policy center that conducts research, educates, and collaborates with other groups to advance these policies. And then the Illinois ACEs Response Collaborative, as I said, is housed here, and we work to catalyze a cross-sector movement, preventing trauma and promoting thriving across the lifespan, not only here in Illinois, but across the country, and we do that through webinars like this, trainings, policy and advocacy work, and research. After the webinar, you're going to get an email from me with a couple of items. You'll get an evaluation survey. Tell us what you thought about the webinar. You'll also get more ways to participate in the collaborative. We, like I said, do trainings and events all across the state of Illinois. We also have a link to our website with all of the materials that I've mentioned, including our previous webinars. And then you'll get a recording of this presentation and a link to register for that next webinar in our Burnout series. You'll see on the side of your screen there is a panel for you to type in questions during the webinar. We encourage you to do so. We'll have a short time at the end of the presentation to talk with Audrey and Lara and ask questions, so please type those in as they come to you. I'll be monitoring that throughout the presentation. Okay, and then to introduce our speakers. I'm very excited to introduce them both since we work with each other. Lara is the director of the Illinois ACEs Response Collaborative. In this role, she leads our policy and capacity building and research dissemination work, focusing on reducing childhood adversity and promoting healing and thriving. Her background is in program implementation, coalition building, and research in public health, especially in maternal and child health. And Audrey Stillerman is the Associate Director of Medical Affairs for the University of Illinois Office of Community Engagement and Neighborhood Health Partnerships, and the Medical Director for the School Health Center Program at UI Health, as well as PCC Steinmetz High School here in Chicago. Dr. Stillerman is a clinical assistant professor in the UIC Department of Family Medicine and is board certified in both family medicine and integrative medicine. And Since 1991, she has been providing comprehensive care for the whole family, from babies to senior citizens, and we are so excited to feature their work together, and I'm going to hand it over to Lara.
Great. Thank you so much, Madison, and good morning or good afternoon to everyone, depending on where you are. I'm honored to be here today with Dr. Stillerman. As Madison mentioned, she is on the leadership team of the collaborative and is really a leader in this work, and we're excited to have her on this webinar. We've got a lot of information for you today, so just to give you a quick run through, we'll start with really talking about what burnout is and how it impacts us and what contributes to it, and then I'll turn it over to Dr. Stillerman and she'll talk about wellness, what that means for us, and strategies that we can really use to move towards wellness in the workplace. We've had an incredible amount of interest in this webinar, which I think is reflective of the fact that burnout is really impacting so many of us and impacting us so deeply. So before we dive into all the technical information, I do want to take a moment to recognize that many of us on this webinar are experiencing symptoms of burnout. It's impacting our workplace, and while we move through a lot of this technical information, I don't want to lose sight of that human side. And we're hoping that through this discussion on strategies that we can actually use, you'll walk away feeling hopeful about how you can make changes within your life, within your workplace, and advocate for more systems level changes as well. So the issue of healthcare burnout is really a matter of U.S. national health policy. Many of you are probably familiar with the triple aim from the Institute for Healthcare Improvement, and a few years ago, family practice doctors Bodenheimer and Sinsky expanded this to the quadruple aim because they felt that including care team well-being was critical for looking at health system functioning and impact. So this is truly a global public health workforce crisis. I'm going to walk through a number of different definitions right now, and the reason we're spending some time on this is because we feel like it's very important to have a shared language that we're using because that is really truly the first step for transformational action, is to make sure that we are all talking about the same thing. So burnout itself was first defined in 1974 by Herbert Freudenberger to describe this deep chronic stress that's coming out of the workplace. Since then, it has been the subject of hundreds of peer-reviewed journal articles, and the World Health Organization recognizes it now as an official syndrome. It has various definitions, but in general, burnout is characterized by a sense of physical and emotional exhaustion, cynicism or depersonalization, which includes negativity, a loss of empathy in personal relationships, also inefficacy or a lack of a sense of personal accomplishment in the workplace, so really feeling like you're not getting anything done, a loss of work fulfillment, especially in roles that previously you found fulfilling. And the thing about burnout is that it's not just having a bad day or a bad week, it's debilitating and long-term and really chronic stress that's coming out of the workplace. So I want to kind of take a step back for a moment and talk about trauma because who we are in the workplace, we bring ourselves and our histories with us into the workforce and into our working lives. So it's important to understand how that plays a role in burnout. Burnout doesn't just come from nowhere, for example. So trauma is a threatening or harmful physical or emotional experience to ourselves or others that overwhelms our resources, overwhelms our ability to cope, and affects our functioning in multiple domains. So SAMHSA calls this the 3 E's, the event, which is either the actual physical or emotional harm or the threat of severe physical or emotional harm, the experience of it, so that some people might find one thing traumatic that others do not find traumatic, and then the effect. So it can really impact us across multiple domains, including physical, cognitive, social, emotional, spiritual, etc. And we know that trauma impacts us through our understanding of our stress response and in our body. So everyone experiences stress on a regular basis, and when you are stressed, if you have a test, if you're going to the dentist, something like that, your stress response is activated and your cortisol levels increase. And then afterwards, you return back to normal. And what we know about traumatic experiences and experiences with adversity and toxic stress is that we develop a sensitized stress response, and we can get stuck either on, for example, where we're in hyperarousal, which includes things like anxiety, restlessness, sleeplessness, hostility, and rage. And we can also get stuck on off, where we have things like depression and a flat affect, low blood pressure. So these experiences of adversity really impact, and the stress really do impact our brain development and inflammation across the body. And we have a lot more information on this. If you're interested in learning more about how this works, you can reach out to us, or we can answer more questions in the Q&A. And we're talking about this now because we know that 50 to 80% of healthcare workers have had at least one childhood trauma in their lives. And then there are additional traumatic events as an adult. We know that training to be a physician and others in the healthcare workforce is physiologically demanding and can be abusive, and that exploitation can really continue on the job. So there's layers of this trauma that are happening to people, both what they come into the workplace with and once they're in healthcare, what happens to them there. And layered on that is what happens when we're exposed to other people's trauma and when we're helping people through their trauma. So that actually impacts us as well. So secondary traumatic stress occurs because we can actually have symptoms of PTSD without having experienced a trauma, but being exposed to it. So our patients or our clients, for example, when we help them through it or we talk to them about it, and that really does impact our health and well-being. And vicarious trauma is this profound shift in worldview that occurs in helping professions when they care for traumatized patients. So your fundamental beliefs about the world are altered or damaged. Your sense of how the world works, what's right and wrong, for example, can really be changed. And lastly, compassion fatigue can occur, and that's the profound emotional and physical erosion in the capacity to care that takes place when helpers are unable to refuel and restore themselves in these really stressful environments where we're helping people who have experiences of trauma. So burnout doesn't just come from nowhere. Some people are more vulnerable to burnout based on their own experience of trauma, based on what's happening in the workforce, and so we wanted to just understand all these other things that are contributing to it. So when we're thinking about burnout, as I mentioned, there's been lots of studies and lots of research now coming out on burnout, and some people are referring to healthcare worker burnout as a moral injury. Not everyone is using this term, but we did want to talk about it to help us understand. So moral injury was first used to describe soldiers' response to war because when they perpetrated or didn't prevent or just saw acts that transgressed their deeply held moral beliefs and expectations, it developed a deep soul wound that really impacted them. And people are talking about this now within the context of healthcare because you have people who have come to healthcare because of a deep desire to heal and help people, but they're unable to provide the high quality care and healing that they are committed to, and they're consistently failing to meet the needs of their patients. And this is creating a deep soul wound for people. And this quote it talks about this impact on the healthcare system, that the increasingly complex web of providers' highly conflicted allegiances and its attendant moral injury may be driving the healthcare ecosystem to a tipping point and causing the collapse of resilience. The thing about the term burnout is that some people find that this implies that there's a personal weakness or a lack of grit and resilience, and this is a sense that burnout implies that it's the responsibility of people. And we know that people in the healthcare workforce have gone through years of training and have taken a lot of work to get to where they are. And so a lack of grit is not something we would normally talk about. And people are really encouraging us to think more about the system and system-induced distress, which is that there are such high volume expectations for healthcare teams. The system has so many inefficiencies, and this as physicians, because that was the subject of this paper, but really healthcare workers in total are just feeling so overworked. And at the same time, without the resources that they need to deliver high quality and equitable care, moral injury is occurring, and that is what's leading to physician and healthcare worker distress. And this really suggests a need for intervention at multiple levels. So moving on now to thinking about the many drivers facing physicians and healthcare workers in general. And we have already talked about a number of different factors, so you're getting a sense of it already. But the point is that the drivers are complex and on multiple levels. And another thing to think about is that some of the things that are contributing to burnout right now were well-intended changes to the system. So, for example, electronic medical records were introduced, to increase efficiency, to help with care coordination. But in reality, they're designed often around billing needs and not so much in patient-centered care. And this is creating stress, and it's a burden to those in the healthcare workforce. Others not so well-intended changes, for example, for-profit hospitals with these huge incentives on productivity and CEOs with salaries in the millions. These are creating environments in hospitals and healthcare systems that didn't exist decades ago, as well as financial incentives for insurance employees and companies to deny care to patients. So, and then we also want to consider people's personal lives. Those in the healthcare workforce have trained for many years, have made personal and social sacrifices, and that's contributing to this, as well as when you're treating people who are sick, that, and sometimes you can't help them heal, that as well is an emotional burden. So we know that there are many levels and layers at play here that are driving burnout. So how widespread is this? So we know physicians between 42% and 78% have reported burnout in recent years. Medscape's 2019 report, the average was 48%, and that's twice the rate as other U.S. workers after controlling for work hours and other factors. And there is variation based on specialty with groups like urologists, neurology, internal medicine, family medicine among the highest specialties experiencing burnout. And this is not, we also know that women physicians are reporting burnout at higher rates than men. This may be a reporting issue that women are more comfortable sharing their mental health issues that are going on, but we do also know that female physicians report more stress with work-life balance than male physicians too, so that might be a part of this. And then we know physicians are not the only group that are experiencing burnout, although there is a lot of research right now on physicians, especially with groups like the National Academy of Medicine prioritizing physician burnout. But in nurses, 22 to 43% of nurses are experiencing burnout, and there's a lot of research right now about the increased risk of suicide among nurses. 30 to 75% of social workers, which I think is a very broad range and probably suggests a lot of social workers are experiencing burnout and we need more research. Similar rates among nurse practitioners and physician's assistants, but really we need more research, especially for medical assistants and other healthcare workers. And the consequences are really, again, multi-level. So there are health consequences for healthcare workers, consequences in the workplace, and for patient care. And I'm not going to read all of this in the interest of time, but we will send out a copy of the slides to everyone. But for healthcare workers, burnout has been linked to cardiovascular disease, alcohol use, and depression. It's associated with a 200% increase in the odds of suicidal ideation among physicians and linked to a shorter life expectancy. And then in the workplace, we find more unprofessional conduct, earlier retirement, leaving clinical practice, and just a loss of productivity as well. And then patient care and patient outcomes are really impacted by burnout. We know that burnout is associated with major medical errors, medical malpractice suits, and other healthcare-associated infections, as well as with patient satisfaction. So this is really taking a toll across multiple levels of the healthcare workforce and healthcare in general. And just returning to this idea of trauma that we talked about before, when we're thinking about the impacts on healthcare workers, burnout's really the result of toxic stress and a sensitized stress response system. The cost of burnout, in addition to the human tolls that we just talked about, there are financial costs. It's 2 to 3 times a physician's salary to hire a new one, and we know that burnout's associated with turnover. So that's between $500,000 and $1 million per physician, and it's 1.2 to 1.3 times an RN salary to replace one. Medical errors are also very expensive, and a 2019 study found that nationally, burnout is associated with $2.6 billion to $6.3 billion of cost annually. And I'm going to turn it over to Dr. Stillerman in a moment, but I want to just take a moment to take a step back again and think about all that we're talking about burnout is really missing a layer and a dimension, and this is kind of a call to action for us and for the field to think about taking a more intersectional approach to burnout. Because when we looked and discussed the drivers within burnout, we are not talking about racism, discrimination, and implicit bias and how those are layering on top of these other stresses and systems level things to impact individuals. Part of this might be we know that there's a shortage of Black men in the healthcare workforce, and that in general the diversity of the physician workforce is not where it needs to be. So part of it is we need just more research on this area. But we know that minority medical students report racial discrimination, racial prejudice, feelings of isolation, and different cultural expectations during medical school that negatively impact their experiences. So there's very real for healthcare workers of color to experience racism and discrimination in the workplace. And so we really do need to take this added layer to understand and adequately respond to burnout in the workplace. And in addition, we need to think about burnout's role in perpetuating disparities in health outcomes. A recent study also found that among white residents, those who had symptoms of burnout, that was also associated with greater explicit and implicit racial biases in their treatment of patients of color. So we really, this is a true moral imperative on so many levels, but we also need to take it, a perspective and contextualize this within thinking about how racism and discrimination is playing a role. And with that, I will turn it over to Dr. Stillerman.
Great. Thank you, Lara. I really appreciate that foundation that you laid for us. So I actually get the fun part of this, which is to think about how we can shift our focus to wellness and well-being. And so what we're going to talk about over the next number of minutes is what is wellness anyway, and how do we achieve it as a healthcare community. So it's very interesting, and I think really speaks to where we are as a nation about a lot of things, but our focus in this area has really been on the problem and not necessarily on what we want and where we want to go. A systematic review of the literature revealed that almost all research has been done on reducing or eliminating burnout as opposed to creating, fostering, and sustaining wellness. And in fact, there is no consensus definition of wellness in the literature, so it's very hard to do research on something that nobody knows exactly what it is. This particular paper proposed a definition that's based on the World Health Organization's definition. And what the World Health Organization says wellness is the presence of positive physical, mental, social, and integrated well-being experienced in connection with activities and environments that allow physicians to develop their full potentials across personal and work-life domains. So absence of distress and presence of positive well-being is one piece. High quality of life, which includes the absence of ill-being and the presence of positive experiences across multiple domains. So this is a proposed definition, and hopefully we'll be able to achieve some consensus around it or a related definition so that we can really move forward in thinking about what kinds of things we can do to both create and sustain wellness and well-being. So back to our stress response system. What's going on sort of behind the curtain physiologically when we're well is that there is a balance between our activating and calming parts of our nervous systems. And so we have this sort of nice wave and flexibility so that we can arouse ourselves, activate ourselves when necessary, and we can calm ourselves down when necessary. So activate ourselves to get to work, calm ourselves down if we need to eat or go to sleep or be involved with people. And what we see on the outside when people have a flexible and balanced stress response system and nervous system is that people have job satisfaction, they have self-reported good health, they're able to engage in positive personal health practices, there's a work-rest balance, and they're able to get sufficient and restorative sleep. So let's take a look now. Instead of looking at the factors that accentuate burnout, we're going to look at some of the factors that seem to be protective. Some of these we know about and some are hypothetical. The ones in bold are the ones that people have described as being present and linked to wellness. So first is a sense of self-efficacy, and this is actually a long conversation, again, which we would need to have in another setting. But this actually grows out of secure and attuned attachment, having basic needs met, a sense of connection and belonging in one's life prior to, becoming a healthcare worker, that, we don't get a sense of self-efficacy, again, just out of nowhere. Robust social support also seems to be very important as a protective factor. People have postulated that positive intimate relationships and lower educational debt can be protective. And then finally, this also has been studied, but rural practice where people feel part of a community that they're living and working in seems to be protective for healthcare workers in terms of burnout. So how do we apply what we know, and what is going to help us find new solutions so that we can both prevent burnout and support wellness? And we're going to go back to thinking about the brain and the nervous system, similar to the way that we think about preventing and healing trauma. But what we really need is for our brain and thus our nervous system and physiology to be in balance so we can be in that sort of wellness resilient zone. We need a settled survival brain, an emotional brain, and we need an alert and active thinking brain to be able to meet the challenges that come our way and also to enjoy living. So our prevention and intervention strategies must focus on physical and emotional safety, on meeting basic needs, and on fostering positive connections, because these are the things that actually help keep us in that zone of wellness and resilience. So we're going to start with systems level possibilities, and we're going to work our way through organizational and individual. And frankly, the biggest return on our action will come from both systems and organizational changes, even though they are a little bit harder to get started. So these are things that advocacy groups, healthcare workers, and patients can actually make happen when we work in solidarity. Some of these you'll recognize are very timely as we approach election season. But first, universal health insurance. People have hypothesized, and there are some experiments in this country about offering free or highly subsidized health professional training. There are states around the country that have tried innovative programs with Medicaid waivers and other financing reform. Folks have suggested simplification and synchronization of insurance and regulatory rules, as well as electronic health records or other ways of recording medical records. Something that some medical schools are beginning to try and also are kind of baked into behavioral health professional training and work are opportunities for reflective supervision. So in other words, an opportunity for employees to come and talk with their supervisors about their own experiences in the workplace. And really that this needs to begin in training and continue throughout medical careers, not just for social workers and psychologists, but for everybody who works in direct service professions. People have talked about regulatory reform. In some states, there is a requirement for physicians in particular to say whether they have ever been involved in the mental health sector, which people have hypothesized has created a situation in which physicians feel like they can't access those services, putting them at risk if they are, if they're struggling. And then finally, this is from me, although I would say that there are others who think this way, but really trying to think about how we can dismantle the system that we have that is really based on some people having authority and others not, and based on academic and financial gain for some and not for others. And so to really make change, we're going to need to address these kind of fundamental frameworks of our healthcare and other systems. So let's talk about organizational level strategies, which, as I mentioned, seem to be more effective than individuals. And again, in bold are some of the things that that folks have studied. So one is to limit work hours and to offer flexible work arrangements. So in other words, to have people pair up so that they're sharing a full-time job, or to allow people to work in hours that can accommodate themselves and their families. And again, this needs to be baked into an organization. Organizations can't be changing every other minute, but there are strategies for making this work. Investing in leadership development of supervisors so that they can learn to listen to their staff with acceptance and non-judgment, and to offer as many opportunities as possible for shared decision-making. The final two are very interesting to me, and they are to create a wellness committee with a wellness champion and a set of strategies, and that this committee actually hosts wellness activities at work or supports people's own wellness activities. And finally, I think this is very powerful, but establishing wellness as a quality indicator for the practice or for the organization. So, just like we are trying to figure out stuff for HRSA or the Joint Commission or whomever, to have employee wellness be one of the things that we monitor and address regularly as a quality measure. Here's some more organizational strategies, and again, the things in bold are things that have been studied, but having facilitated discussion groups that incorporate elements of mindfulness, reflection, shared experience, and small group learning have been very successful. There was one study that found statistically significant improvement in participants that was sustained at 12 months with only providing this one paid hour every other week. So really a minimal amount of time and money went into supporting this intervention that had a big impact over time. Establishing a culture that prioritizes all relationships and teamwork has not been studied extensively, but feels like a good idea. The third thing is also something that people are beginning to study more extensively, and that's supporting expression of compassion. And what folks have found is that when healthcare providers take the time to make human connections that actually help end suffering, both patient outcomes improve and medical costs decrease. Interestingly, this compassion helps to reduce pain, improve healing, lower blood pressure, and alleviate depression and anxiety, not only among patients, but also among caregivers. And then the final thing is people have hypothesized that reducing stigma around getting emotional support, particularly for physicians, will be helpful, as well as actively encouraging staff to get help when needed. And there's some interesting work regarding EAP and the benefit of having a well-run and well-functioning EAP that's connected to the workplace. So people will often say, well, like, how do we measure burnout, and how do we measure wellness, and how do we monitor what we're doing? And there actually are a number of tools that are available. In fact, many validated tools. There's just a list of some here, the Maslach Burnout Inventory, the Wellbeing Index, the ProQual, the Mini-Z. There are others as well. The bottom line is that there really is no consensus on which screen makes the most sense to use, or even how often to screen. So we have some kind of general rules to think about that may be helpful as we're thinking about how we know what's going on and how we monitor things. And the first is, we know that more than 50% of healthcare workers are reporting some symptoms of burnout. So some have advocated for using universal precautions, which means to assume that everybody might be burnt out to some degree until we know otherwise, and that we need to act accordingly in our organizations and systems to support people. The next is really observing signs and symptoms, so really knowing our coworkers, both as supervisors but also as co-staff, and checking in on people when they're not looking as we expect. And we want to check in on people in these ways by using open-ended questions and ongoing conversations. So just, how are you feeling? How are you feeling about work? And to really build relationships that are built on supportive communication and caring observation, because this is really protective for folks, and this is going to be the way to either help them solve problems or connect them to other help that they need. So we're going to actually take a look at two specific case examples that are a little bit different, but both have some really interesting features. So the first is for Virginia Mason Kirkland Medical Center, which is in Washington State. It's an outpatient clinic in a larger health system with 30 full-time clinicians and more than 70 non-clinician staff. And what Virginia Mason Kirkland did, in my opinion, is actually capitalize on stuff that we're sort of supposed to be doing anyway, and that people are talking about. Most of these things are not radical at all, but they really got serious about them, and they had some really nice results. And so some of these things are like optimizing their workflow and using all of their people to the full extent of their education and training, so not sort of getting caught up in Byzantine rules about who can do what. They standardized some clinical roles. They really focused on using team care, cultivated a culture of mutual caring and respect, and also invited people's ideas. They used their hiring and onboarding as a time to talk about all these things. They had regular discussions, and they really solicited their employee feedback. Now, what they did do that's kind of radical, and I think is very interesting, is that they built in pauses during the clinical workday. So in other words, there were no patients scheduled at a point or a couple of points during the day so that people could catch up on what they were doing, go to the bathroom, take a breath, whatever they needed to do. And that is not something that I've experienced in my work life. So I thought that that was a really interesting idea. So here's what they got out of doing all those things. They had what looks like a very appreciative non-clinician staff who felt content and engaged, 90% of them. 93% of clinicians also reported being content and engaged. And they had employees who really believed that the things that they were doing had improved their well-being and reduced certain drivers of burnout. So now we're going to move to a huge system at Ohio State University and Medical Center where there are 66,000 students from multiple disciplines and 45,000 faculty members and staff with 800 medical students and 2,200 nursing students. So like about as big as we can imagine other than, say, the federal government. And they had a multi-pronged approach. So they did things in their learning environments, like in the College of Nursing and the College of Medicine. What they did in those settings were they had more counseling and mentorship support. They had discussion boards. In both places, they really focused on wellness. The College of Nursing gave extra credit for wellness activities. The College of Medicine actually hosted a required curriculum. One of the things the College of Medicine did, which I highly support, and I wish all higher education institutions would think about, but that was that they instituted pass-fail evaluations. And that's a whole other long conversation, but I think a very important one is how do we take the sting out of and the impact out of high-stakes testing. And both of these colleges engaged in ongoing evaluation. At the same time, in the emergency medicine residency program and in the Wexner Medical Center, there were new programs that were created or existing ones that were highlighted. And so in the residency program, a lot actually focused on sort of social cohesion. So family inclusion, peer support, social events. And at the medical center, they did some things on self-regulation. Schwartz rounds are actually multidisciplinary rounds, again, that are sort of a group reflective supervision, and they had well-being retreats. And they, being a huge organization, were able to really study deeply some of the impact that they've already realized. And what they found was that they had a cumulative productivity net savings of over $15 million from their wellness programming across the university, but that they had a $3.65 return on investment for every dollar that they spent, and that their faculty and staff and students reported decreased anxiety, depression, stress, and suicidal intent with increased academic performance and just increased levels of healthy lifestyle behaviors. What I'm going to show you next is just sort of a little, like a logic model that they made, but they used the social ecological model to kind of ground their programming and their measurement and outcomes. And so they really thought about their individual student or worker in the context of their families, in the context of the organization, and then also kind of the broad context of the social society across time. And so I think this is a creative and well thought out way really to use an existing model that is important for a lot of our work. So last thing that we're going to talk a little bit about is individual and collective care. And collective care is really, in my mind, how we take care of each other, whether it's our coworkers, whether it's supervisors and their staff, and then the things that we do for ourselves. So this little wheel has a number of the things that help kind of, again, to keep us in that zone of wellness and resilience, by getting enough sleep, exercising, laughing, breathing, eating well, enjoying ourselves, taking time for reflection. And we can't do this. We can't have sole responsibility for ourselves as individuals. Yes, we should take some responsibility, but also our workplaces need to be set up so that we can engage in some of these things across the workday, because the workday is long. And we need to contribute, and also we can expect to receive from our co-workers and supervisors care, so that we can engage in these things that we have to do, and so can they. And so we have to have a little ecosystem in our workplaces. So the people as individuals are getting what we need, and we're helping each other do that. So to just sum it up, as Lara mentioned, healthcare worker distress across the board is a huge global problem that compromises the well-being of our workforce and of our patients. It has huge financial and social costs. The research to date has really focused on the problem of burnout for physicians, rather than on understanding and working towards what well-being might mean for everybody. We talked a little bit about some emerging and promising organizational and systems level strategies that are absolutely worth the investment. Our Ohio State example definitely reveals that. And one of the things that I'm hoping that we'll see in the upcoming few years is how we begin to bring some of these promising practices to scale. What we know is that both prevention and solutions are going to take time to fully understand and to create. They're going to require our collective work across sectors with systemic commitment and action. And we also know that they're going to be really worth it, whether we're talking about worth it for physician and healthcare worker and patient well-being, or whether they're going to be worth it on a financial scale. And it's just going to take time. We're going to need to fasten our seatbelt. This is a thorny problem. So we're going to stop there so that we have some time for Q&A, but we really appreciate your attention.
Thank you all so much. And like I said at the beginning, there is a question box on the side of your screen, so please type in questions that you have for Dr. Stillerman and Lara. And I'm going to get us started with one. You mentioned 2 case studies where folks have implemented some of these practices you talked about. I'm wondering if in either of these case studies, or just in general, there's any talk about the relationship between different disciplines too, and how the self-care or the burnout prevention programs impacted, for instance, doctors and nurses, or nurses and social workers.
Yeah, no, I'm really glad that you asked that, Madison. You know, because for right or for wrong, probably for wrong, physicians are often in charge, and so the spotlight is on them. So most of the literature that we were looking at really was about physician well-being. There is literature in the nursing research and social work research. Kirkland in particular talks about multidiscipline teams, a focus on that. And so I think that what they were doing was they were creating those, and certainly those could be units that could either come up with certain practices that would work for them, could implement certain practices within their team as part of their huddles or other things that they might do. So those can be units both for planning and for implementation.
Well, this is a great sort of lead into this question. So how can we utilize some of these strategies to a broader nonprofit health and human service?
And I'll just jump in for 1 second because I was going to say this. I know that many of you that are participating in this webinar are from other social service organizations and not necessarily within healthcare. And the issue of burnout is cross-cutting. It's not just for those in healthcare settings. In fact, I just did a training on burnout for a group of community organizers and activists, and we know that the rates of burnout there are very, very high. So I know there's another question around, is burnout as prevalent in other helping professions? And we know that, yes, it is. We have some of those statistics about social workers and others as well in the beginning. So I just wanted to make that point off the bat, that this is very relevant for everyone.
I'm just going to jump on that, Lara, and that is not even just in the healthcare professions, but we know that teachers experience burnout, firefighters, police officers, really for sure anybody who is a direct service provider. And even we were just discussing before we started the webinar, the sort of ethos of work in this country is not a place where most workers actually feel like physical and emotional safety and a sense of connection. And so this is relevant, you know, even say if you work at McDonald's or something like that. The other thing is that the strategies for prevention and healing are pretty universal, whether you're a doctor or whether you're a receptionist in the hospital or whether you're a community organizer or the executive director of a nonprofit. You know, again, thinking about how do we, as far as we can go, but how do we support people in getting their basic needs met, feeling comfortable in this setting and like they're valued, and how do we support a culture of positive relationships, and then how do we manage our work such that, you know, people don't feel like they're doing irrelevant things or that they are being asked to do things beyond what they've been trained to do, and how are we creating space during the workday for regulation and again, you know, opportunities to sort of balance our nervous system. So, again, there have been many years in my work where I had to figure out like when I was going to go to the bathroom. That's ridiculous. So, you know, having times when people can, you know, actually manage their activities of daily living and when they can go outside for a minute or when they can connect with each other, all those things that we know are critical for our being, you know, our best selves.
And I'm actually going to ask a question of you while you're talking about this, but can you talk a little bit more about some of these mindfulness practices, how they help us with self-regulation and some examples of how you can incorporate that?
Sure, yeah. So anyway, so again, regulation is sort of this balance, both in our nervous system, but also overall physiologically so that we can either be activated or resting, depending on what the case may be. And regulation really comes from a balance in the brain of the brainstem and the midbrain and the cortex. So when the cortex is really able to kind of be in charge and the brainstem and the midbrain are sort of calmer, it's much easier for us to be regulated. And so some of the activities that we're talking about, whether it's yoga or whether it's meditation or whether it's coloring or whether it's dancing or whether it's journaling, all of these things actually, because of characteristics about them, which I can talk about in a second, help to actually settle down the brainstem. When we do them with other people, they actually create this sense of social support. And so the cortex is really able to function at its optimal capacity. And so some of the features of regulatory activity are that it is rhythmic, it's repetitive, it's relevant. In other words, we have the skills that we need to be able to do it. It's respectful of our culture. It's pleasant. And so when we think of all those examples that I just gave, they have varying numbers of those characteristics.
I'm going to actually join two of our questions together because they're both about resources. So I know we'll be sending out a list of the resources associated with this, but we had someone ask about via the 2 case studies, are there any playbooks or toolkits that are available to replicate some of the findings they found there? And then another person asked about the idea of moral injury and more information around that and how to address that.
Yes, so we will send out, we have a full, as Madison mentioned, kind of 2-page references list for everything that we have cited in this webinar, as well as some additional resources. So that will go out in a follow-up email either tomorrow or Monday. So you'll get that full list, which includes the articles about moral injury. And you can also follow up with us directly, and if you have specific questions. But,
right. And, I just wanted to say, in terms of the case studies, both of those are written up in detail on the National Academy of Medicine website, and we're going to send you the link to that. But there's like a little white paper and some more information about both of those things that I think would be helpful in thinking about, what, if any, of those things might work in your particular setting. And, I know I was dismissing a little bit the wellness assessments, but I think an assessment that's very worth doing in one's own organization is, what are the 3 to 5 things we love about this place, and what are the 3 to 5 things that are driving us crazy, and then sort of thinking about how do we enhance those things that we love, and how do we actually tackle the things that are making us nuts, and so that there can be sort of an organic approach to problem solving. And I think just, again, doing that collectively is another thing that helps prevent burnout, because we're all working on the same page towards a common goal.
So we had someone ask, I noticed the proposed intervention for promoting wellness in the financial domain is reducing education debt, and you mentioned that yourself. So do you have any strategies that you advocate for and see in practice that have successfully promoted that long-term financial wellness that prevents so many people from joining these professions to begin with, but then B, leads to a lot of stress and burnout for them?
Right, exactly. So I'm gonna talk to you about a couple that I know about, but I think that this is an area that deserves a lot of attention. So NYU Medical School in the last year actually made their medical school tuition free. So in terms of, the ability for folks who might not be able to afford medical school to go, that's huge. Now, what I don't know is what they did about, their admissions criteria. So in other words, if they maintain the same admissions criteria, they're going to get the same demographic kind of student, and so there won't be as deep an impact in terms of diversifying the workforce. But still, I think that this is a very interesting experiment. They're also in Cuba, and I believe there are other places in the Caribbean too, you can go to medical school for free. And so I know that there are not an insignificant minority of people of color who have chosen to go to those medical schools for the very simple fact that they won't have debt. The other thing that exists right now that I'm not sure how much people know about, but I think is worth talking about and worth leveraging is if one goes to work in a federally qualified health center, and this is true for doctors, for nurses, and for social workers, and I imagine it's true for psychologists, although I don't know that exactly. There's a loan repayment program. There used to be National Health Service Corps, which actually paid for medical school so that you would, you would leave debt-free, and then you had to make a commitment. You did service for however many years they paid for. So in other words, if they paid for 4 years of your medical school, then you had to go work for 4 years in the placement wherever it was. Now, the sort of bigger program is this loan repayment program. But again, if you make a commitment to a federally qualified health center, they will pay for some of your debt. And so I think that program definitely could be expanded. And I really think that the National Health Service Corps program should come back.
And I'll just also add to that, that when we're thinking about some of the lower salary professions as well, if you think about medical assistants, for example, that how are we investing in career ladders and training programs at that level too to help people advance in their careers so there's more opportunities for financial growth. And then also thinking, how we are talking about trauma, secondary trauma, and these other components too. How are we really supporting the whole person in the workplace to help them excel as well, so that we can help people move on the path to financial independence and sustainability.
Right.
We had someone ask, do you know of ways to effectively begin these conversations with teams that are already very burnt out and there's already this seeming lack of empathy or blocks to doing this work because they're already experiencing these symptoms?
Yeah, that's a fantastic question. I think, unfortunately, is a bigger problem than we would hope it is. So the thing that I think, again, back to sort of our trauma conversation, is before we can really think, we've got to get our brain stems, midbrain, and physiology into a place of calm. And the best way to do that is to do some of these regulatory activities. So I think before even thinking, planning, addressing, the thing to do is at staff meetings or morning huddles or whenever people are gathering for the posse that are the instigators, to begin to lead work that helps us come into that zone. And we've started doing that at my job in our meetings and are encouraging it in huddles, but just to take literally 1 to 3 minutes longer if you have it, to do a few yoga poses, to practice mindfulness, to color, to sing together. There are just many, 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 many activities that don't cost money, that don't take a very long time, but really help to get people settled and grounded. And if you dose those things throughout the day a few times, it will really help people move from that place of burnout. The other thing I would say, though, is if folks are burnt out because of what's going on in their lives outside of work, and work is just contributing to that, thinking a little bit about, does the workplace need to have an emergency fund for staff? Do staff need to be referred to EAP? Are there other kinds of ways that we can support people so that their basic needs are met, and also so that they're in a place of, wellness?
It looks like we are rounding out, and I want to be respectful of everyone's time. So again, thank you so much to Dr. Stillerman and to Lara. And again, just to reiterate, this is only the first in our series on burnout and well-being. We are going to be hearing from folks who have put some of this information you've just heard about in practice and more ways you can integrate the prevention and addressing of burnout into your work. A reminder, you'll receive all of this information in your follow-up email, including the resources that Dr. Stillerman mentioned, a recording of this webinar, and other information that you've learned about today. Again, on March 12th, we'll be hearing from Linda Grab of Emory University's College of Nursing and Elaine Miller-Corres of the Trauma Resource Institute, in Claremont, California, on their community resilience model, which is a skill-based mental wellness and prevention program that focuses on reducing symptoms associated with stress and trauma. And they're going to be discussing how it's been particularly impactful in preventing burnout in healthcare professionals and addressing this, utilizing some studies they've done with hospital-based nurses. So I want to emphasize it's not just for nurses, it can be applied in any setting. So we encourage all of you to attend and learn more about that. And in April, again, we'll be welcoming Addie Stuart to discuss integrating yoga as a trauma-informed wellness practice. So please join us and learn more about ways that you can integrate this knowledge to prevent burnout in yourself and at your organization. And thank you again to Dr. Stillerman and Lara and to all of you for joining us. Thank you so much.